critical issues in treatment that David Mee-Lee is conducting for the Bureau of Justice Assistance Drug Court Technical Assistance Project. And I'm just happy to see that we have a whole array of disciplines represented: judges, probation, treatment, coordinators. As you probably have seen in the descriptions, David is really introducing a whole change in our paradigm. For those of us who work in the justice system are used to measuring compliance based on time, 30 days for this, 60 days for that, and those who work in the public health and medical field who recognize that people do not respond to a disease and the treatment of it necessarily in the same pattern of time that the justice system might expect. So I think this is really some fascinating issues that David is going to be introducing, and I want to just turn them over to David now so we can start our webinar. So thank you, David. Thank you, Monica.
Thank you, Carolyn and Monica. So let's get started with a little bit about terminology and the whole issue of compliance versus adherence. And we want to kind of make the distinction between those two, especially as it relates to trying to create the kind of behavior change that will increase public safety and decrease legal recidivism and crime. And just a reminder that I'll be finishing, try to do this in about 40 minutes or so that we have time for questions even in today's session, but we do have a follow-up session that you will need to re-register for tomorrow at the same time as today's, where the whole session will be focused on questions that that don't get answered today, and we encourage you to email those, send those in between time too. So a reminder that we will continue the discussion tomorrow at the same time. But Webster's Dictionary defines comply as to act in accordance with another's wishes and with rules or regulations. And I'll talk about how that is an appropriate mentality to have when we're talking about criminal justice systems. But when we're talking about treatment, and when we're talking about wanting to create lasting change that increases public safety, a treatment concept is much more about adherence. To adhere is to cling to, cleave, to be steadfast, hold fast, and to stick fast. In other words, if we're going to help people to make actual change, the focus in treatment should be much more on adherence, not compliance. Now, most drug-addicted clients and people with, problems with addiction know the difference between comply and adhere. They know how to adhere. In other words, if you told them that across town promptly at, 4 o'clock, you could get whatever drugs you want, whatever quantity, whatever variety, but you must be there promptly at 4 o'clock. They would know how to adhere. They wouldn't be just trying to comply and saying things like, well, I don't know if I can make it at 4 o'clock, and how about 5 o'clock, and I've lost my bus pass, so I don't know how to get there, or I feel a little flu coming on, so could I go next week? They would be there at 5 minutes to 4, they'd be there at 3:30, I'll walk on my knees if I have to, I'll be there. That's the kind of adherence to treatment that we want to see in offenders, clients, participants who are sent to drug court and other problem-solving courts. If we just see compliance, and you often hear clients talk about treatment this way, well, I don't know if I can make it to group, or because they're really just focused on jumping through the hoops and with rules and regulations. And I want to make a distinction between the criminal justice view of problems and how to solve them versus treatment. And when we're talking about drug courts and other specialty courts, we're really talking about people who the court has been gracious enough to say, we think this person is challenging the public safety and repeating in terms of crime because they may have an illness of addiction or mental health or both. And so we're going to be gracious enough to give them a chance at treatment because we think that if they get treatment and actually change, then that will help the criminal justice goals of public safety and so forth. But criminal justice and treatment have two different kinds of missions, and we don't want to impose the criminal justice mission onto treatment if treatment is about trying to make people really enter into recovery and make a lasting change process. So just review what I think legitimately is the focus of criminal justice is the 3 C's. That criminal justice is correctly focused on consequences if you don't comply with the law, because we're trying to control public safety. We have speeding signs that say 65 or 70, and you don't have a choice. You have to act in accordance with others' wishes and with rules and regulations. It isn't up to each of us to decide, will I go 65 or not? And if you don't go 65 and somebody catches you, there will be consequences for not complying with the law because we have to control public safety. That is appropriate. The problem is that when then we mandate a person to treatment and we start referring to treatment as in terms of consequences, compliance, and control, we're getting our missions mixed up, because in treatment, the focus is not on consequences. The focus is on outcomes and progress. And if somebody isn't doing well, as evidenced by positive drug screens or by poor attendance or by a reactivation of drinking, drugging, anger, and so forth, we don't think of that in terms of consequences. We think of that in terms of poor outcomes in treatment, which requires reassessment and a change in the treatment plan. And we don't want people to be compliant with treatment, just sitting there doing time. We want them to do treatment and change. So in a treatment context, compliance is the wrong term. We want to see adherence, where somebody's really trying hard in good faith to change their behavior. And this is not about controlling a person in treatment. This is about engaging them and attracting them into recovery. So the importance of working together as court teams and treatment providers is the need to promote these kinds of things. And what I'm presenting today is really to start opening up the conversation. I don't want to pretend I have all the answers. I don't want to pretend that we should all do it exactly as I'm saying. What I am saying, though, is here are the challenges when we interface between the criminal justice mission of consequences, compliance, and control, and the treatment mission, which is attracting people into recovery and promoting real, lasting, accountable change, so as to reach the common purpose and mission that we all want: public safety, sustainable change that leads to a decrease in legal recidivism and crime. And as we work together, that means then we have to remember we have a common purpose, so we all want the same outcomes. We have to recognize that not every client and participant and offender sent to treatment is ready to embrace abstinence and sobriety and recovery. So when a court mandates abstinence, we're mandating a particular stage of change which may actually need to be worked towards in treatment, that somebody can't mandate abstinence and perfection any more than you can mandate in mental health court non-psychosis, non-depression, non-suicidality, or non-mania, and then sanction a person if they get suicidal, manic, or have a panic attack. And so the same principle should apply, that we recognize that all participants in drug and specialty courts may not be at a stage of readiness to embrace abstinence, and that's the problem, which needs treatment, which is why they're going to treatment. So we have to have a consensus philosophy about addressing readiness to change and see that as a treatment issue, not as a compliance court order issue. And this requires then, as we work together, to promote consensus on how are we going to combine our resources and leverage to effect real change, responsibility, and accountability. Because we all need each other to reach the common purpose and mission of the goals that we all want. So that means my recommendation is for judges to mandate assessment and treatment adherence, where the expectation is then for treatment providers to work with the court to give the kinds of reports that are actually promoting real change and doing treatment, not doing time. And judges and courts not to mandate a particular level of care and a particular length of stay, or specific treatment strategies or services like AA or getting a sponsor or medications. Those decisions need to be made by treatment people who have the expertise and scope of practice to follow the court mandate of assessment and treatment adherence. So what the court should be interested in hearing is this person actually doing treatment in good faith, and are they actually changing towards the goals we all want of public safety and sustainable change? And give me the kinds of reports that reassure me that this person is not threatening the public safety and that they're actually changing in a way that will assure us all that we're going to get a good outcome. But because we come from different systems with a criminal justice mission of consequences, compliance, and control, and treatment with a mission of engaging people in recovery and real change and lasting, sustainable, accountable change that reaches the goals of public safety, there's going to be communication difficulties, and there's going to be often conflict resolution, because we recognize that each stakeholder in this process has their own mission and their own area of expertise, and we have to sort of decide between each other, how do we communicate together to not lose sight of what we're trying to achieve. Now, I'm going to present a couple of phasing system protocols, not so much to say these are the ideal phase of treatment protocols that you should have, or phases of drug court. In fact, in many ways, they're not ideal, and I'm going to point out where I think they could be improved. But I think these are fairly typical phasing system protocols that I am presenting. And what I'm going to talk about is how do we move from structuring phases just based on the structure of time frames and start moving towards phases based on the achievement of functional milestones. In other words, how do we move from compliance to adherence? How do we move from doing time to doing treatment and change? Because if phases are based just on time without functional milestones, it too easily promotes compliance, doing time, versus adherence, doing treatment and change. So the way that we're going to do this is I've highlighted certain words in yellow, and we'll point out how I think when we have those kinds of words in a phasing system, they promote more compliance and not real change, or they're ambiguous about functional change. For example, often we say that is the offender participating. Well, participating may just mean passive attendance, and passive attendance is just doing time, not doing treatment and change. So I'm going to highlight words that I think promote a more compliance approach. And then I'm going to, in yellow but italics, indicate words which may push us in the direction of adherence and functional improvement. When we're talking about compliance, as I said, compliance with court orders is appropriate and consistent with a criminal justice mission. When we're talking about compliance, you have to comply with speeding laws, you have to comply with other laws of the land. That's appropriate. But when we're talking about change and accountable, sustainable change, we need to think more in terms of treatment terms, of adherence with treatment plans that allows individualized treatment to happen. And individualized treatment is about focusing on helping them attract this person into recovery and making sustainable change. Here's one typical phase, phase one, orientation, where the goals are screening and assessment and referring to treatment, placing a person in a community-based treatment, identifying barriers, and continuing drug use with the expectations that A person will weekly or bi-weekly show up in court, enter into treatment, and then here's the words here, compliance with all court orders. Well, if the court order is to be mandated to assessment and to adhere to the treatment recommendations of the treatment provider, that's fine to be compliant with all court orders. But if the court orders a particular level of care and a particular length of stay and a particular state of perfection, that is outside the scope of practice of judges in terms of treatment. So what we're looking for is compliance with the court order to receive assessment and adhere to treatment, but what we're really looking forward to is adherence to treatment plans developed in collaboration with the client based on a clinical assessment. And then typical in other expectations are urinalysis 3 times a week randomly. The first phase orientation, when the participant is compliant with all court appearances and is participating in substance abuse treatment and has completed any sanctions. So again, these terms are really putting the emphasis on compliance and doing time when we really want to start languaging things that are in the direction of, is this person actually changing? Because just participating and getting checked off that they showed up at a group or an AA meeting and that they completed sanctions is really not assuring us that the person is actually changing. Phase 2, this is a not untypical phase, continued abstinence and recovery, enrollment and participation. Again, there's that word participation. Really, treatment providers should be providing a much more robust report on not just is this person sitting in group or showing up, but are they actively changing? Here's again, identify home group if required to attend. Well, my point is who's requiring it to attend? If this is a judge requiring it to attend, I would have concerns about that because that's not a requirement based on a treatment assessment. And again, too much encourages the participant in drug court to just make sure they hand in an attendance sheet at an AA or NA meeting. We've all heard of clients who show up to a meeting, get something checked off, and then sit up the back or even outside, smoking a cigarette, talking, and not even really engaged in the meeting. We don't want reports of people showing up and getting checked off a list. That's compliance. We want to make sure that treatment is making real treatment plans that address real change. Again, expectations, engagement in substance abuse treatment. Well, what do we mean by engagement? If engagement just means they signed up for a program and enrolled, that's not engagement towards change. And again, here's words like attendance, if required, identify a home group. Well, many clients can identify, here's my home group, and get checked off for attending a meeting. That doesn't say anything about are they actually changing. So these words are not powerful in terms of really focusing on the goals that we want of real, lasting, accountable change that increases public safety. Here are some more language. When the participant in phase 2 is expected that she expresses and demonstrates commitments. Expresses is just words. And so again, pushes things in the direction, well, I can comply with that. I'll say whatever they want me to say. I'll say whatever they want me to hear. What we really need to see is demonstrates. Is the treatment provider providing the kinds of reports that indicate that they are working actively in treatment with this person who is now demonstrating functional change, not just expressing it or attending or participating. But you see many of the other words are still participant must be compliant. Again, the focus is on jumping through hoops. Actively participating. Many clients think they're actively participating to sit in group, say a few words, say what they want you to say, and you hear clients say this. I'm here in group, aren't I? What do you expect me to do? Aren't I complying with the court orders? well, no, you're complying with the court orders to attend treatment, but you're not adhering to treatment by just sitting there not even knowing what your treatment plan is and even saying things like, well, what do you want me to say? It's not what I want you to say, it's how you changing in a way that we can report to the court that you are reaching functional milestones that will assure everybody that the public safety is being advanced. And so again, when we see words like they're referred or recommended by the court, my concern is recommended by the court based on an assessment or just recommended by the court because they're saying you need to attend AA or need to attend this program. So looking at how do we move to wording that focuses on functional change. Here in phase 3, success or progression, those would be good terms that are pushing us into functional change. But then we'd want to hear from reports from treatment providers, what's the evidence of successful progression? We don't just mean that they attended all prescribed sessions or that they sat in group and didn't cause a fuss, nodding politely and saying the right things. That's not successful progression. That's just doing time, not doing treatment and change. And we don't want people just to be required to attend meetings and say, yes, I have a sponsor. What are they actually doing to demonstrate working through a recovery program? So again, whenever we see these words, required and comply and so forth, we want to look for words that are more in italics. Phase 3, when the participant is compliant with all court appearances, is participating. Again, compliant, meaning they just jump through the hoops and do what they're told, is not what we want to see when a person's in treatment. We want to see them adhering to an individualized treatment plan focused on issues that are interfering with the kinds of behaviors that increase public safety. Phase 4, pretty typical again, continued abstinence and recovery. You can see that these are the kinds of things that are in many phase protocols. And then we see expectations, completion of all court conditions. Well, again, just completing something doesn't mean that you've changed. Participant has gained insight. That's moving in the direction of milestones of change. But insight in a treatment program isn't just a person saying the right thing. Oh, I realize now I have a drug problem. I realize I need to stay away from those friends. Anybody can say anything. Insight has to be demonstrated in terms of behaviors, in terms of who are the trends you're staying with now, who are the ones you're not hanging out with. Tell me about an AA meeting where you went. Tell me about a story that you heard that impacted the way that you're going to act in your daily life. You know, the treatment provider should be able to give specific examples of real change, not just evidence that a person attended or is saying the right things. Phase 4, treatment team must be in agreement that the patient has successfully completed all requirements. Well, the treatment team, again, should be focused on not successfully completed all requirements by participating and just showing up, but successfully completed milestones of change. That's what we're really trying to move towards. Now, the ASAM criteria, which we've talked about in the first session, and these dimensions provide us a structured assessment that the treatment provider should be using, if not the ASAM criteria, but of course I'm biased. I think these are giving us the dimensions that promote real change. But the provider should be looking at a multidimensional assessment where in the assessment that the court should mandate, they will identify which of these dimensions, and it might be several, or it might be all of them, it might be one or two, provide for problems that the client is having to work on, and really to create a treatment plan with the client that they are willing to do, and then to hold them accountable to adhere to that treatment plan, to then track and make sure that progress is being made. For example, if somebody on dimension 3 has an anger problem, which gets out of control and ends up creating an offense or getting into trouble, then for that particular person's individualized treatment plan, anger is going to be an issue that they're going to need to demonstrate real change in. If on dimension 4, a client is ambivalent about even being abstinence, we don't want the court to just mandate abstinence and then expect perfection. And then if a person hasn't worked through their stages of change on that, of course they're going to use, and then they get sanctioned for it. If a person is ambivalent about whether they want to be fully sober, or they agree that they want to stop methamphetamine, but they're not sure about stopping marijuana, that's a treatment issue that has to be worked on. And if they get a positive drug screen and they're willing to change their treatment plan in a positive direction, then treatment continues because they're adhering to treatment. If on dimension 5 you have a person who doesn't have a clue about how to deal with cravings to use, they're going to need help with that. Not everybody gets the generic relapse prevention plan. We have to look at what for this particular person is the trouble they're having with relapse or continued use. If on dimension 2 they have a chronic pain problem, which is going to set them up for difficulties with continued alcohol or other drug use, there needs to be a specific pain management program. So we could go more into this, but just to give you the idea that each person's assessment has to involve a particular assessment of these issues with an individualized treatment plan that then is worked with the client to start at a stage that they're able to make changes, and that a treatment provider needs to give robust reports to the court about how they are actually changing in all of these areas that impact public safety and legal recidivism and crime. And so judges can't be expected to understand what this client needs to then be mandating specific treatment strategies from the courtroom. That's treatment providers' responsibility to make sure there's treatment adherence to treatment. So that's why I say, please, judges, mandate assessment of treatment adherence and then hold treatment providers accountable for a clear evidence that the person is changing in the direction of public safety. So here's another example of a phases protocol. Again, not to say this is the ideal, but where we tried to add in more of those italics adherence parts and to explain a little bit more about what direction should we move to be able to move from doing time and phases that are focused on length of time to moving to doing treatment and change, where the protocol should be focused more on actual functional milestones that both the offender and participant is aware of, that the treatment provider is aware of, and all the court personnel are aware of. So here's a typical phase system. The phases of participants: track 1 for high-risk, high-need people needing highly structured and that should be at least a minimum of 12 months. But again, the length of time should vary depending on individual progress, because many clients can sort of bite their tongue and hang out for 12 months complying, but not really make significant changes. Of course, others do make changes, but we're really trying to make sure we hit that population, that 50% of people who drop out of drug court. For those people who are often just going through the motions doing time, we want to ferret those out sooner rather than later. And that means having protocols that are addressing milestones of change, not milestones of time. This example then illustrates an attempt to increase wording that promotes individualized treatment adherence and change and functional milestones, and I tried to indicate those again in yellow italics. Now, I say that this is all to open up a conversation, that this needs improvement. This is a work in progress. This needs all stakeholders getting around the table. And as I said, reaching some consensus on how do we move to this direction and start changing our phases protocols from simple compliance to change. Here's an example of phase one orientation, where we're looking at intake, needs assessment and orientation, and you know, formulating a treatment case plan. That's all good as long as it is then an individualized treatment case plan. Now, as I said, most phases have some sort of minimum length of time. So this one says a minimum of 2 months, but I added in or earlier, in other words, less than 2 months, in collaboration with the treatment provider if functional change is achieved. So if we've met those objectives of an intake and a needs assessment and orientation and treatment planning, and it's done earlier than 2 months, no need to just have somebody wait 2 months if the treatment provider in collaboration with the court team can say, no, this person is actively in good faith engaged in treatment, we've worked out a treatment plan, ready to move on from that. Requirements often in phase one are to complete screening and assessment, placement in a treatment program. And then here's that word participation again. We don't just want participation, we want active involvement in an individualized treatment plan based on the priorities and needs in the 6 ASAM criteria dimensions. So, you know, a treatment plan that looks the same for every client in mandated to treatment, which should be suspect, because that would indicate that it hasn't been an individualized treatment plan, that it's just a paperwork treatment plan that the person is expected to comply with. But this means identifying treatment goals that are focused on this particular person's needs, and you can see that there can be all kinds of permutations and combinations when you have 6 assessment dimensions. Attend court hearings, fine, but when they attend those court hearings, we should be focused on, is this person really developing a meaningful treatment process? So begin, for example, begin the development of a meaningful support network, not just develop a support network. Anybody can say, I'm going to AA, but this means in the ASAM criteria dimensions, has there been a careful assessment of dimension 6 and their recovery environment? And is AA appropriate for this person? This may be a person who will more meaningfully get a support network out of their church or synagogue or their community of faith or some other cultural community. We shouldn't just be mandating AA and NA as if that's the only support network. It has to be meaningful to this particular participant. And it says support network which the participant will be invested in. And invested has to do with dimension 4 readiness to change. Is this person at action for even going to a support network? We don't want them just to get something checked off that they attended an AA meeting and then think that all is well. The treatment provider should be doing a careful assessment to see if this person really is invested in it, and are they changing it, and then are they utilizing that support network? And utilizing means actual attendance with ability to relate with people and identify with them. Do they actually have names and numbers that they're calling? Do they actually have a sponsor, not just in name, but somebody they're using? Do they have a home group where they are known by those people? So a treatment provider is in the position to really see, is somebody utilizing it, or did they just get something checked off? In residential, if somebody's in residential in the orientation phase, you know, we often have these time frames. It's recommended inpatient treatment should be a minimum of 90 days. Well, minimum of 90 days is fine, but what if they are achieving goals that they don't need residential anymore? So I added in, or earlier, if the treatment provider verifies stable progress and improvement such that the participant can safely transfer to a less intensive level. So there's nothing magical about 90 days, and if you mandate 90 days, you often see clients sitting there marking time, disrupting the program because they're just waiting out their time. This is not about waiting out time. This is about demonstrating functional change. And if the treatment provider can verify that stable progress has been made, they're not cured, they're not a model citizen, but they don't any longer need residential as a treatment, then they should go to a less intensive level when they need to go based on functional milestones, not based on time. If they're an outpatient, again, it says participate 3 times a week in group therapy and participate in individual therapy a minimum of once per week. Well, the court shouldn't be mandating particular frequency of treatment. That should be based on assessment of the person's needs and their progress. So I added in, or as deemed necessary by the provider, based on demonstrated functional improvement in treatment plan progress. So this is always a conversation between the treatment provider and the court about, is this person actually changing? Don't lock us into specific doses of treatment. That's not the court's expertise or place to do. That too much promotes compliance with doing a certain number of groups and so forth. People advance when they are actually not just showing consistent attendance, because as I said, attendance can mean you're just showing up, but actively and meaningfully engaged. And then sanctions are imposed not just for a positive drug screen, but sanctions are imposed for lack of meaningful good faith participation in treatment. And the treatment provider can identify this person is just showing up, doing time. They're not meaningfully in good faith doing treatment, and judge, I recommend a sanction for this person. But don't sanction them for having a poor outcome that needs treatment, like a positive drug screen. If the person's willing to change the treatment plan in positive direction, then treatment adherence is happening and treatment should continue. But if somebody's just doing time and the treatment provider doesn't think the person's actively in good faith but doing treatment, then a sanction is appropriate. I'm going to move more quickly through the rest of the phases because they all have the same sort of message. But here again, phase 2, demonstrating functional improvement in problems that threaten public safety or increase legal recidivism crime, actively addressing those issues. So we want to see in treatment that treatment is addressing all of the issues that threaten the public safety, and that they are focused on functional improvement, not just a particular number of sessions or a particular length of stay. Again, we often get focused on length of the time, minimum of 3 months. Well, fine, but I say, or earlier, in collaboration with the treatment provider, if functional change is achieved. So there's nothing magical about 3 months as producing real change. It's, is the person really changing? And again, the same kinds of issues, identification of a support group. Well, we don't just want them to identify a support group and especially mandate a 12-step group if that's not appropriate to this person's particular assessment. So it should have words like, or a support group in collaboration with the treatment provider who assesses that this is part of the individualized treatment plan. So this means an assessment of a person's Dimension 6 recovery environment, their culture, their spiritual orientation, their belief system, their friends. AA might not be the most appropriate group for that person. Smart recovery might be, some other community of faith. And again, we don't just want family and systems to be involved. We want them to actually be engaged in individualized family treatment if necessary. So again, any words that just look like sign up for evidence-based parenting, many people can just sign up, but that doesn't necessarily mean that they're changing. And anyway, why is the court telling a person to sign up for specific classes? That's a treatment planning issue. If the treatment provider feels participant is ready based on demonstrated functional improvement, then they can be stepped down to a less intense level. So it should be based, again, on functional milestones, not on time. And that's the message of many of these words that I've inserted here in italics. Advancement, a participant will be monitored for a minimum of 6 months. Well, if somebody is being monitored for 6 months, you'll notice that I switched it here and I said, or longer, in collaboration with the treatment provider, if there's lack of functional improvement and treatment progress. If we're just going to track somebody for 6 months as if they're on probation and we're just going to track them for 6 months and then they do their time, when we're talking about treatment and functional change, it may mean longer than 6 months if they're not demonstrating change and are needing more treatment. So again, the emphasis in italics is on consistent attendance and demonstrating functional change, adherence to the individualized treatment plan, and meaningful good faith participation. If people are not adhering to the treatment plan and are not in good faith, meaningfully participate, then they are, in my opinion, open to a sanction because they are not in compliance with the court order to do treatment if they are not actually doing treatment, just doing time. Again, the same sorts of words: involvement in a support system. The treatment provider needs to actually demonstrate that they are actively involved, not just attending and getting something checked off. Evidence that the participant has developed pro-social peer and leisure activities. Are they actually changing their friends? Are they actually developing the skills to handle leisure without, reoffending? And again, the length of phase of treatment, a minimum 4 months or earlier if the treatment provider can demonstrate stable progress towards public safety goals. I'm not going to go through the rest of these because they're often just giving the same message, and you can read them there. I want to just skip to the last section here where we're talking about graduation. The whole terminology of graduation, again, is doing a certain amount of time, when I would suggest we think of other terminology that is focused on, if you want to use the word graduation, but is focused on the achievement of certain milestones, not using graduation in the terms of having just done a certain amount of time. So to end off, but to open up the conversation, we should be sanctioning for a lack of good faith, effort, and adherence in treatment, not sanctioning people for signs and symptoms of their addiction and or mental illness. So just getting a positive drug screen, we shouldn't be sanctioning for. We should sanction for if that person gets a positive drug screen, they don't do a good faith effort to change their treatment plan. Treatment providers are responsible to keep the court apprised of any risk to public safety and should not be giving just reports about passive compliance with attendance and drug screens. If a client is not changing their treatment plan in a positive direction, then they're just doing time. So if you see a treatment provider allowing a person to just skate through treatment and attend the program, but is not actually changing their treatment plan in a functional direction to actually do treatment and change, then they're not actually doing treatment, they're just doing time. Incentives for clients should be explored and matched to what is most meaningful to them. Is this a person who they're very focused on wanting to be able to see their kids again, but they've got a restraining order because they have done things that have scared the family? Well, a good incentive would be helping that person develop functional change to be able to see their kids again. We're not just talking about incentives of a coupon to spend $20 at Target. And then there should be a close working relationship between the client, judge, court, team, and treatment providers to actually actualize this approach. It's going to take a conversation together if we're really going to be able to move from doing time to doing treatment and change. Here's the ASAM criteria, and here's some websites, again, that can provide you with some resources. So, Caroline, I want to stop at this point and see if we have any questions. If not, I can go back and review some things I went over quickly, but I'd like to start the conversation reminding you all that you can re-register for a follow-up Q&A session same time tomorrow so that we can open up the conversation more about this paradigm shift.
Yes, thank you, David. I guess one of the issues, and this is the question we have, and we have people, I didn't mention this, from probably 30-plus states, so everybody's different, but the question is there a sample treatment plan with these specific specifications and design? And I just want to mention before you answer this, and I wish we had the capability of polling, but maybe you can do this, and Monica, there's a way to do it in our follow-up question. we find in our technical assistance that often the team does not have a copy of the treatment plan, let alone the participant doesn't have a copy of their own treatment plan. So it's difficult for them to be talking about objectives when they don't even have that in front of them, let alone the team and the judge knowing what the expectations were. So I'm just going to throw this out, and Monica, I don't know if there's a way you can, or people can maybe add that in the comment, whether you have that or not, but isn't, David, if you can address that,
yes.
Is that something that's critical for people to have?
Well, firstly, the person who should know the treatment plan best is the participant and the offender. So a judge could ask a client when they attend, not just are you attending treatment, but tell me about your treatment plan. And if you get a blank look from the client, that tells you something about the quality of the treatment that's happening on. If the treatment plan that the client says, what treatment plan, Judge? I know I signed something, or I just have to attend all these groups. That's a compliance sort of treatment plan. What you'd want to be hearing from the client is, what are the issues you're working on your treatment plan to help you to change such that you increase public safety and don't reoffend? If the client looks at you blankly, then that's a concern. The judge could find that out from treatment providers. When you have a meeting with the treatment provider, say, what issues is this person working on that will increase public safety? Now, I would have no objection to certainly the client should have their treatment plan. I would have no objection to the court having the treatment plan. They should know what they're dealing with. Of course, the client gives permission so that we are in keeping with all 42 CFR and HIPAA compliance. But the treatment plan shouldn't be some secret, I guess is what I'm saying. Now, the court doesn't need to have all of the specific progress notes. If somebody has trauma and they've been sexually abused, the court doesn't need to know all of the details that the person may want to keep private in terms of working through their treatment. But the court should have an idea about what the person's working on that will be functional milestones towards public safety and decreased legal recidivism and crime. Is there a sample treatment plan? Well, one of the reasons it's hard to give a sample treatment plan is because if you look at those 6 dimensions, you may have a client who on dimension 2, the biomedical dimension, I'll just get it up here so those of you not familiar with all the dimensions, if they have a chronic pain problem which has contributed to writing illegal prescriptions and trying to get OxyContin, that person's going to have a different treatment plan from somebody who has no chronic pain problems, but whose biggest problems on dimension 6 were all their friends drinking drug, and on dimension 4 where they want to stop methamphetamine but are not sure they want to stop marijuana, and who on dimension 5 doesn't know what to do with cravings to use. That person's treatment plan is going to be different from another person whose dimension 5 problem is they can handle cravings to use, but they have very poor peer refusal skills. So whenever they run into friends who offer them drugs, they have self-esteem issues that make them hard to say no to them. And who, in addition to that, on dimension 3, has bipolar disorder, or who has panic attacks. That person's treatment plan is going to be quite different, working on panic attacks, where they've now overused their Xanax prescription and got into trouble with drugs because of that, and then started forging prescriptions to get it for their mental health problem, versus the person who forged prescriptions for their chronic pain problem on dimension 2. I'm trying to indicate that a particular person's treatment plan should be individualized based on the issues in any or all of the dimensions that interfere with functional change that threatens the public safety and recidivism and crime. So a sample treatment plan, my worry would be somebody would start using that as the treatment plan when it should be based on an individualized assessment. But we can do more training on what you should see in a treatment plan to give you confidence that a person is getting treatment that is focused on real change, not compliance and attendance.
So let me ask you a follow-up question. Would you suggest that the treatment plan be organized in those 6 categories? Would that be helpful?
Well, I think the assessment if you wanted to organize them under those 6 dimensions, or even if you're not organized under the 6 dimensions, the narrative clinical summary should address there are no issues in this dimension, but here are the issues in this dimension, and so forth. The treatment plan wouldn't necessarily have to be organized under the 6 dimensions, because there may be some clients who don't have a problem in certain of the dimensions. They're totally physically healthy on dimension 2. They don't have a co-occurring mental disorder, although they're going to have on dimension 3. This is where criminogenic factors could come in, antisocial personality styles. Those things would come under dimension 3. Dimension 6, again, antisocial, friends and that sort of behavior would come under dimension 6. So there are some of the things in the criminogenic factors that would fit in certain dimensions, but what would be more important to me is that the treatment plan addresses particular issues. You could put a problem in a treatment plan and say this is a dimension 3 problem or a dimension 5 problem. That would be a good way to indicate that we know what part of the assessment it's based on, but I don't think you'd have to slavishly do a treatment plan under the 6 dimensions if that doesn't apply to this particular client.
Would you feel it's helpful for the team and the judge to have a copy of the multidimensional assessment so they can see that maybe 1 is not applicable, 3 is, whatever the issues are?
Well, again, I think where some anxieties come from treatment providers and the client is that you don't want the client holding back from talking about sexual abuse or other things if they feel like it's going to go into a thing that people outside the treatment. So I wouldn't be in favor of sharing every detail of the assessment. I'd be in favor of sharing in a report what are the functional improvements in which dimension that this person's working on. They have anger and impulse issues that get them into fights and get rearrested. They have friends who will use, which gets them to reoffend public safety. So we can identify those problems. So the treatment plan could identify major problems that are going to be needing to see. That, I think, can be shared, but I would be anxious about clients not being open in an assessment if they thought everybody's going to read every detail.
Yes, okay, thank you. I'm not sure if we have any other questions at this point. So we have a few more minutes if you wanted to highlight.
What is the process, Carolyn? I know we're having this follow-up session tomorrow. These are important topics. Do people send an email about any, and let me say, I am totally happy for people to disagree with anything I've said. This is not about, ramrodding through some perspectives. This is really opening up the conversation. So it's very important that anything that doesn't make sense or that participants have anxieties about, that we use the time tomorrow to start addressing those. So what is the process for people to say, well, this I agree with, but this I don't agree with, or what about this situation? How would we handle that? Do they send an email or what?
I'm going to turn that to Monica, who's handling it.
If anyone has any questions or comments about today's webinar, please feel free to email them to justice@american.edu, and we'll be sure to get all of those questions and comments to Dr. Mee-Lee before tomorrow's session.
So let me ask
justice@american.edu. Okay.
Yeah.
And so let me ask one more question. What would be useful for a report, a progress report for the team to have and for the judge to have in preparation at the staffing and the hearing? Dr. Mee-Lee, if you could just kind of give, should it be organized by the dimensions or not?
Yeah, well, if there's a good working relationship together and a common consensus and language, a treatment provider could right up front say, Judge, I want you to know this person is in treatment and is fully adherent with their individualized treatment plan and is actively and meaningfully involved, and that here's the progress on the 3 top issues that threaten public safety. And in other words, you give a progress report on the treatment plan, as it were, not just to report on is giving all unit drug screens needed and attending all group. I mean, I would de-emphasize those kinds of reports that basically look the same for everybody, and, you know, participating in treatment, attending all prescribed groups, compliant with drug screens. That's not all that useful. I would see a report that addressed, for this particular client, these are the issues that the person is working on. This one is showing good progress to the point where I think that they would be safe to go into a less intensive level. This one, the person is still struggling with, but is willing to change their treatment plan in a positive direction. And then the judge could know, when they're talking to the client, tell me again what you're working on to help you improve your behavior and functioning. And if the client didn't mention those same things, that would be a concern. Either the treatment provider hasn't conveyed the treatment plan clear enough and it's not a collaborative process, or the client makes it look good while they're in treatment, but then they can't relay to the judge what they're working on and how they're working on it. So I think a report that outlined the major functional changes and the progress of that would get the court and the client and the treatment provider need to be on the same page.
Well, thank you. I know one of the things that we also ask the treatment providers to do is to suggest any ways the court can reinforce treatment. So that's
yes, and that's where the recommendation would be, would judge, this person is attending, but they just sit there. They're not really actively involved in their treatment plan. They don't even work on the treatment plan. I recommend a sanction, a graduated sanction, because now they are out of compliance with the court order to do treatment. And then if the judge says, well, aren't they in your program? Yes, judge, but they are not in good faith doing treatment. They're just doing time. So, or, you know, this is the kind of thing that we would want to help reinforce the direction of the treatment plan.
Okay, we have a couple more questions which we might not have time for, but we can deal with this tomorrow. But have you written an instrument to be used by the treatment provider that focuses on change that teams could use to get a quick picture of treatment progress?
Well, when you look at each of these 6 dimensions, there are standardized instruments that look at somebody's withdrawal status, somebody's physical health, somebody's mental health. I mean, there are all kinds of standardized tests, say, for Dimension 3 of vector depression inventory, anxiety scores. There's readiness to change, standard tests that you can look at a stage of change. Socrates, SOCRATES, and there's the Eureka, the University of Rhode Island Change Assessment. But each of these dimensions don't necessarily need just an instrument. A good treatment provider, I mean, in research projects, you often use these standardized assessment rating things. But this is not about doing the math. This is about expecting the treatment provider to look at. If somebody is having trouble with anger, and on Dimension 3, you don't need an anger management rating scale to know, are they able to work on that, you know, get them to role play in group an angry situation. And if they don't know how to demonstrate how to handle that without getting to a fist fight, you don't need a rating scale to work that. You say they don't know how to deal with their anger. Or if the person's having outbursts in residential treatment or group, then they're clearly not changing. So yes, you can have instruments that rate progress in each of these dimensions, but what's more important is the treatment agency actually working on functional changes? If somebody's on Dimension 6 still hanging out with all their friends who drink and drug, you can find that out without doing a rating scale. You know, you can say, tell me about your friends and so forth.
Okay.
Was there another question there, Carolyn?
Just a quick question here, and then we will follow up. And also, okay, would the term quality of compliance be applicable?
Quality of compliance. Well, compliance itself is acting in accordance with other wishes and with rules and regulations. So a good quality of compliance would be sticking to 65 speed exactly, right? If it says 65. and not going 66. You could talk about quality of compliance in that way, but when you're talking about change, we want to look at quality of adherence in a treatment mission. Is this person adhering and working as hard as they can on their treatment plan? Because it's an oxymoron. You can comply with the treatment plan if the treatment plan is not your plan and you're just acting in accordance with rules and regulations or with somebody else's wishes. It's not your treatment plan. So it's a bit of an oxymoron. I don't mean to be splitting hairs, but the whole concept of compliance is that I'm obeying rules and other people's wishes. When it comes to treatment change, you have to be obeying things that you're willing to put effort into, not just jump through the hoops.
Well, thank you. I know it's a couple minutes afterwards. I just want to kind of put an advertisement out for our session. I think it's March 29th, where we're going to be talking about challenging cases. So please keep in mind, send some challenging cases. We'll talk tomorrow about, the information to include. But what we want to do is have the benefit of Dr. Mee-Lee's expertise in helping guide through some approaches to situations that have been challenging for the various drug court teams that are working with them.
And a heads up, Carolyn, Monday, April 4, we're going to be talking about engaging participants in a self-change process with a follow-up on April 5. So
right.
March 29 for your cases, April 4, engaging participants in a self-change process, and April 5.
Right. Well, thank you, everyone, and we'll look forward to talking with those that want to explore questions tomorrow at the same time. Thank you.
Thank you.
Okay, bye.
Thank you. Bye-bye.